Good evening, and thank you for joining us for this evening's Zoom Town Hall. To protect participants' privacy, all attendee names and webcam video will not be visible and will be off. Please utilize the question and answer feature to ask any questions throughout the presentation, and we will answer at the conclusion of today's talk. At this time, I'd like to introduce Dr. Gian Parikh, the co-director of the Minimally Invasive Urology Institute and professor of surgery at the Warren Alpert Medical School of Brown University.
Good evening, everybody. Thanks for joining us. It's kind of a crazy time. I'm sure you guys have done multiple Zooms and gotten used to Microsoft Teams and all this fun stuff that we never thought we would have to, but here we are. I want to first off say Dr. Golianen, who is my partner in crime here at the Minimally Invasive Urology Institute, who's helped build this place into a world-class institution in the United States and beyond, is not able to be with us. He's attending to some family matters in Belgrade. He'll be back very soon. He's had some issues with his mom, and so I will let him explain all that. I don't want to invade his privacy, but he's there now. Tonight's goal is to sort of go over where we are with the Minimally Invasive Urology Institute at the Miriam. So we'll give you some updates. We would like to provide you with the current state of sort of healthcare in Rhode Island and how it's impacting urology and the Miriam. Want to give you a little sort of spiel on the impact of urologic cancers in Rhode Island. It's fascinating and scary at the same time. One of the goals for this evening is to tell you about an exciting new project that we are starting, which is called a GU Registry. So GU is Genitourinary, which is another sort of an acronym for urology. It's used interchangeable with urology. So just GU essentially means urology. So just keep that in mind. We want to give you some basic accomplishments that we've had to date and sort of next steps, and hopefully give you a really good idea of what's happening and how possibly we can all mobilize and help. So first, let's get this slide out of the way, the COVID-19 and patient care update. Like with everything else, we've had to deal with this over the last year. We've had restricted visitations, but interestingly, we've continued with surgery, at least in urology and in cancer care, because cancer care is so critical. We've been able to maintain our surgical abilities with a very limited sort of shutdown, let's call it, maybe 6 months ago, which lasted about 6 weeks. So we are full force, coming through the holiday and have a busy agenda. We are doing in-person and telehealth appointments, so we're taking advantage of the governor's ruling on that and continue with telehealth, which likely will be here to stay going forward. We've got updates with caregivers. Pretty much everybody's masked with N95s or equivalents to protect both patient and caregiver. This statistic hot off the presses, 63% of caregivers have been vaccinated with either the Moderna or Pfizer, including myself. I think it's time to get everyone vaccinated, and I know really everyone in the community over a certain age should be vaccinated ASAP. And then we're waiting delivery of additional vaccines. One exciting piece of information and news that's occurred this year is we once again made the U.S. News and World Report among 1,495 programs in the U.S. The Miriam Hospital's urology program ranked in the top 50, putting us in the top 3% in the nation, and one of 3 hospitals in New England. So it's really cool actually to see when you read the U.S. News and World Report, you'll actually see Miriam Urology. So it'll say, Yale, New Haven, Brigham and Women's, and then Miriam Urology. So that's 2 years in a row, and we hope to keep that going. One of the things that was frustrated with when I came to Rhode Island in 2006, and at that time was, our ability to recruit and retain. And so, rather than being complacent and just satisfied with what we've done, we continue to be aggressive with recruitment. With the Miriam support, really, we've been able to do it. It's been a combination effort between Brown Urology and the Miriam, and Lifespan in general. So we were able to recruit Sam Eaton. He is taken over our Newport operations, but he works closely with the Minimally Invasive Institute at Miriam and does his robotic surgeries here. He's already done close to 10 cases since his arrival, which was just a couple months ago. So he's from Duke, seasoned, been out for about 7 years, and whose wife has actually taken a nice position at Women and Infants as a director of endocrine medicine. David Sobel was a fellow here, and he decided to stay on. He was excited about what was happening at the Miriam. He moved a couple blocks from here, and he is originally from Vermont and then Brown University, and he does minimally invasive surgery. And then the latest recruit, which started just 2 weeks ago, is Dr. Hyams. Dr. Hyams is trained at Hopkins, actually NYU, and then Johns Hopkins in Baltimore, and then has been in practice at Columbia Presbyterian for the last several years. And he joined us just 2 weeks ago. Wanted to move his family up, heard about the Miriam's exciting development, wanted to move to coastal Rhode Island, and here he is. So now our goal is to foster these young folks and then hopefully grow their practices in both clinical and research arenas. Exciting for me, one of the things that our program director, Christopher Tucci, and I really focused on, and with the help of many, we were able to recruit Dr. Philip Caffrey. He's our research program coordinator. I started about 9-10 months ago, and through COVID has really made a lot of progress, and I hope to fill you in on a couple of those things today. Rebecca Ortiz, she's a research assistant that we were also able to hire. This is through funds that we were able to secure either through research or other means, and that's their exciting addition and really have pushed our mission of research forward. We also acquired the Da Vinci Xi surgical robot. I'm sure you've heard about the robotics program over the last 15 years. Since I sort of did the first prostatectomy in 2006 here with one of my former partners, we had an older system, and we've sort of taken that to the next level. This is the latest and the greatest. It's smaller, it's thinner, it's ergonomically better. It's decreasing our surgical times, and there's new things like laser guided incision for port placement and things like that. A lot of bells and whistles on it, but really for staff in the OR and for the team, it's just a lot easier to use. It doesn't take up space, and it has advanced capabilities with vision and movement, which is really helping our physicians. So just to put it in perspective, now we have 2 robots at the Miriam. They sit in adjacent rooms. One is the Xi, and one is an older system, which we are hoping to upgrade very soon, based obviously on funding and utilization. So, just to recap, sometimes it gets confusing. Like, what is the Minimally Invasive Urology Institute? And really what one should think of it as is it specializes in things like adrenal mass care. Adrenal glands are small glands located above the kidneys, and we take care of those. BPH, which is something that all men get, 50% of men over the age of 50 develop BPH, which is enlarged prostate, which causes a lot of urinary symptoms. We deal with bladder cancer, PSA elevation, which is a screening test used for prostate cancer, blood in the urine, kidney cancer, cysts in the kidneys, kidney stones, penile cancer, prostate cancer, testicular cancer, and UPJ obstruction, which we're not going to get into technicalities of that, is essentially a congenital abnormality that occurs between the kidney and the ureter, which is the pipe that drains the urine. But we are robustly dealing with all these disease states, not just dabbling, but really getting a lot of referrals from outside for these. So, to flip gears a little bit, switch gears a little bit to cancer, because this is one of the themes for tonight's conversation, and to educate everybody on the cancer registry. Approximately 1,300 Rhode Islanders will face a diagnosis of cancer this year. As a high volume robotic program in the region, and combining our care with our surgeon scientists, the MIUI, which is the Minimally Invasive Institute, is pretty well positioned to research urologic cancers and impact the care of Rhode Islanders. We just don't want to take organs out. We want to look in, we want to prevent, we want to figure out why it's happening, why is it so disproportionate here? So if you look at just bladder cancer, for example, bladder cancer in New England is a disproportionately high rate of bladder cancer in Rhode Island. It's one of the highest in the United States. Women in Rhode Island have the highest average incidence in the United States from 2012 to 2016. Women and minorities often have worse outcomes. Part of this is access to care and other issues. Occupational exposure has been linked, particularly maybe from the jewelry industry or the manufacturing, industry as potentially a major cause, but we don't know 100%. The economic burden in Rhode Island just from bladder cancer is close to $22 million a year. Prostate cancer, which is also very common, 1 in 9 men diagnosed with prostate cancer every year. Second leading cause of cancer death in men. Risk factors include family history, Agent Orange, tobacco use, ethnicity, age, and as pioneers in robotic surgery for over the last 15 years, having done several thousand cases, putting all these patients into our system, we owe it to ourselves to figure out more than just how to take a cancer out, but it's really to look at it more holistically. We collaborate in this specific disease state and others with our multidisciplinary teams here at Lifespan and Brown. Kidney cancer is a third major cancer in urology. We see a lot of it here. If we look back, and don't quote me exactly on this, but I think before Dr. Golianin really put the pedal to the metal, let's say, we did about less than, I think it was like 85 to 90 cases in a year. Now, 2 to 3 years later, we're up close to 200 cases a year, getting referrals from all over Boston, Connecticut, and beyond. The disease is increasing. And as I just said, we've seen an 83% increase in renal surgeries over the year. Excuse me, let me just make sure my screen got popped off a little bit. Some potential risk factors are tobacco, obesity, high blood pressure, and environmental exposures. So one of the things that I mentioned, we wanted to talk about the GU, or Genitourinary Urology Tumor Registry. It's the first of its kind in Rhode Island. It's essentially, I'll call it a project, what aims to lay out the groundwork for a statewide, multi-institutional, so not just the Miriam. We need data from Roger Williams, South County Hospital, Kent Hospital, Rhode Island Hospital, Newport Hospital. And we want to put all this together and with its one mission, which is to advance research, promote prevention, and address treatment disparities. Like, why are we seeing so much bladder cancer in Rhode Island? Is it the water? Is it really the manufacturing industry? We don't know. Ultimately, and most importantly, we want to improve health outcomes for the people of Rhode Island. So the aim of the project is to as I said, to establish this statewide registry. Sounds simple. It's not. We need to advance research, promote prevention, and address all these disparities through this registry. So how do we get there? If you look at from 1970 to currently, how did we get to this position? Really, we've seen increase in incidence of all these diseases, as I mentioned earlier, and we need to figure out, what happened in these years. We have an IRB approved protocol, which can go back, retrospectively review every single patient that initially came through Lifespan. So I had mentioned we want to capture everything, but initially we could only capture our systems patients, which make up the majority anyway. But so that's Rhode Island, Miriam, Newport, and the Lifespan Cancer Institute. We have a HIPAA privacy, and we're HIPAA privacy compliant, and it covers a lifetime of the patient. And much of the data, unfortunately, is in paper charts, and this is prior to the whole use of electronic medical records, so it makes the task even more daunting. So what have we done so far? We recruited, as I mentioned, Dr. Caffrey, who's incredible. Our research assistant. We've studied 1,817 robotic prostate cancer patients that underwent surgery. In that process, we have to identify their treatment, like what kind of surgery, because even within the surgery, there are many different types. What happened with their pathology afterwards. We have to look at all their CAT scans, their biopsies, and then all the demographic stuff, which I won't expose you guys to over and over again, but just in general, for all the cancers, we need mortality rates, race, ethnicity, occupation history, exposure, smoking status, etc. Same thing with bladder cancer. We've identified close to 3,349 cases of bladder cancer, and we have to look at every single parameter that we can think of to include in this registry. So just to put it in perspective, here's one patient. Let's call him John, 81 years old. Dr. Golianin gets a referral for bladder cancer. Dr. Golianin takes the bladder out, the prostate. When you take the bladder out, you actually take the prostate out too in a male, and he does a lymph node dissection. The patient had chemotherapy in the past, He's had multiple recurrences. He got treated with a medical therapy called BCG. He's had CAT scans, biopsies, and on and on. So he has a lot of these different things and data points that we need to capture. We need information for surgery, pathology, as I mentioned, and so on. And besides all these clinical things, we need social history. As I mentioned before, alcohol, tobacco use, chemical exposure, family history, and so on. So a lot of different data points that we need to extract. So in doing all this, we've already established relationships with multiple governing bodies. The Rhode Island Department of Health is, we need to get the maternal, paternal birth, death records. The labor and transportation can give us occupational history. We did submit a grant to the Robert Wood Johnson Foundation to get other demographic data, such as where people live, their economic status, and so on. And then we'll use our collaborators at the Research Center Institute and Brown University to further collaborate and try to get this as robust and pure as possible. So far, what have we done? We just recently started. We've interestingly already observed that in 2006, when I took a prostate out, it was stage 2. Now when I take a prostate out, it's stage 3. So why is that happening, right? That's a huge undertaking to figure that out, but that's like something very exciting that the Miriam could lead in as we go forward. We're seeing an increased number of kidney cancers. Is it just because we're getting more referrals because we have such great physicians and Dr. Golianin leading the way in that fight? We don't know. We're seeing a delay in bladder cancer treatment. The thing with bladder cancer, it's not like prostate cancer. It can't wait. It kills much more aggressively. So we're observed that already. And we anticipate all these numbers to go up. So our time, we're as we say, it's hot right now to do all this research, and we hope to continue to do that. The Rhode Island Foundation, which has been very difficult to get some, they're a great organization, but very, they scrutinize at the highest level. They gave us seed money, $25,000 grant that Dr. Caffrey and the team put together. And it was a tremendous accomplishment, which really gives us a great foundation because now we're legitimized and we can now go get other money, hopefully. And that's not a lot of money, as you guys all know. It can go quickly. They need to support research staff and salary, especially during COVID. It's been challenging. We have a lot of hours that need to be spent to do all the things that I just sort of outlined for you guys or outlaid for everybody. Just to put it in perspective, it's about 600 data points or fields per patient, and it's about 4 hours per patient that needs to be spent to create this. The time and the effort seem, like it's a crazy amount of resources, but it's needed and it's necessary. And again, it's one of its kind. We could be leaders in the United States. It's an advantage of being a small state. Sometimes you can actually accomplish this goal and be one of the only states in the United States to have such a beautiful program. We need additional support. We want to merge EPA data with GU, with the cancer diagnoses. We want to explore social determinants of care, explore geographic relations, and raise awareness in Rhode Island. What is the factor that's leading to, all these increases? What can we avoid? And I think we can get some answers as we collaborate with everybody. So I know we're limited on time. I just wanted to speak for 15 to 20 minutes and open it up for some questions. So I appreciate everyone listening. Thank you.
Great. Thank you so much, Dr. Freak. A number of great questions have come in so far, so feel free to send additional ones in. Our first question, is an elevated PSA always prostate cancer?
So good question. Elevated PSA is not always prostate cancer. Actually, it's often not. PSA is a protein. It's produced by the prostate, and it will be in the blood. And it can vary depending on your prostate size, whether you have had infections before, and a number of other things. So basically, the golden rule is confer with your medical doctor or your urologist and establish a trend and see if that PSA is flat or if it's going up in a sort of upward fashion. And if it is, then it's more worrisome. So the answer is no, it's not always prostate cancer.
Fantastic. Thank you, doctor. Another question. Should those with a long employment history in manufacturing be screened for bladder cancer with a CAT scan?
Yeah, that's a great question. To put the answer in, not yet. I don't think the information is out there to say that. You know, what you should get screened with is with a urine analysis done, which most primary care physicians will do on the annual visit. If that shows any microscopic blood, which these tests have become very, very good and very specific, then that will prompt the CAT scan and so on. Obviously, if you see blood in the urine, you want to go forward and tell your doctor, and that'll prompt a CAT scan.
Great, thank you. Another question that has come in is again about prostate cancer, and it's is an MRI adequate for diagnosing prostate cancer, or is a biopsy always needed?
So an MRI is an adjunctive test, meaning it will help whether to decide whether we need to do a biopsy in some cases. So to put it in perspective, there are cases where an MRI is negative, meaning there's nothing visible by the radiologist, but then when I do the biopsy, there's cancer. And then there's other situations where the MRI looks a little worrisome, and then I biopsy and it's not cancer. So it's become very, very, it's a confusing time with MRIs. So again, it's the doctor-patient relationship on how to use an MRI to help. So ultimately, tissue diagnosis with a biopsy is the way to tell. You know, is actually a better way to tell right now. And who knows, in 10, 15, 20 years, perhaps the imaging will get even better.
Great, thank you, Dr. Preek. A question here is about kidney cancer and one of the treatments for it, a partial nephrectomy. Can you talk a little bit about the research and the outcomes of doing a partial nephrectomy for kidney cancer instead of a radical or taking the entire kidney out?
So a lot of kidney cancer now is picked up a little bit earlier than, for example, when I trained. And in those days, the cancers were a lot bigger. So we would end up having to take the kidney out. What's happened over the last 10, 15 years is we have just, learned a lot from the science, and we're picking up a lot of cancers at a lot smaller stage, which is good. But then you don't want to take the whole kidney out if you don't have to. So we're doing what's called partial kidney removals. And that's one of our, big things here. Besides the other cancers, this is a huge technical win here. We are able to remove just the cancer and leave as much kidney as possible. And that's a good thing because that'll help in one's life, because the more kidney you have, the better.
Great, thank you, Dr. Preek. One of our final questions, is bladder cancer inherited? So can you get it from a family member?
So you can. I think there's a genetic component to anything, whether it's kidney stones, large prostate, and so on. And then there's environmental factors that pile on top of that. So it's not a direct one-to-one link. There are certain subtypes of bladder cancer that if one has, then they're at higher risk. So don't, just because grandfather had bladder cancer doesn't mean it's going to be passed down. No, it's actually majority of the time it's not passed down. But there is a genetic component, and then environmental things like smoking and other risk factors like obesity, diabetes, those things may add a little fuel to the fire, which ultimately can lead to, the bladder cancer forming.
Great, thank you, Dr. Preek. And for our final question is about water in Rhode Island. Can you talk a little bit, Dr. Preek, about the impact of water, whether or not it's the water quality or dehydration or overhydration, which can cause some of these urologic cancers?
So good question. I don't think there's any direct evidence that the Rhode Island water supply has any link to causing increased bladder cancer, but that's why we're forming the registry. We can look back and see trends, changes, and work with our governmental agencies and figure out if there is a link. In general, hydration with water is critical and should be somewhat preventative of things, of any kind of cancer. But there's no direct link with the Rhode Island water supply. It's theoretical. And so I don't want anyone to think that there is a direct link, but it's something we will look into because we don't know what causes all these bladder cancers.
Great. Well, thank you so much, Dr. Preek. Our time has come to a close, but if anyone is interested in learning more, feel free. You can reach out to us with the contact information here, or can always reach out to Cheryl, and she'd be happy to connect us. So thank you for joining us, and have a great evening.
Good evening. Thank you.